Today on Next Gen MD, we are tackling one of the most common and most confusing symptoms patients struggle with: leg swelling. Swelling can be frustrating, uncomfortable, and sometimes even scary, especially when you don't get clear answers. Many patients tell us that they've been brushed off, given a water pill like Lasix without real testing, or they're pushed towards procedures like venous ablations without anyone stopping to explain why the swelling is happening in the first place. But swelling isn't a diagnosis, it is a clue. And it can come from a whole range of causes: vascular issues like PAD or chronic venous insufficiency, heart failure, kidney problems, lymphatic disorders like lymphedema, fat distribution disorders like lipedema, or simply general edema from medications or lifestyle factors. So, today we're going to break it all down. What causes swelling? Which symptoms point to which condition? What tests actually help? And what patients should be asking for to get the right diagnosis and the right necessary treatment. So, joining me is Dr. Lily Johnston, and I think together we're going to give patients the clarity they've been missing. Right, Dr. Johnston? At least we hope, right?
We're going to give it a good shot, Kim. Let's do it.
So, before we dive into the causes, can you explain what swelling actually is at the physiological level? Is it always fluid buildup, or are there different mechanisms that lead to swollen legs? And we're talking aside from just an acute injury like a sprain or a break or something like that.
Sure. I mean, swelling is, think of it like an overstuffed suitcase. There is more material in between the vessels and the skin than it wants to fit there, but it could be sort of saltwater fluid that generates kind of pitting edema. It could be protein rich fluid. It could be inflammatory cells. So if there's a situation, again, like you mentioned, an acute injury, typically there is some fluid there, but it's also all the inflammatory cells and responses that can build up in the area outside of the vessels. So it's not always fluid. It's probably the most common thing that builds up in the tissues.
Okay,
And
so
you
go
asked
ahead.
about why that happens.
Yes.
Sorry, there are a couple of issues, and two of them are pressure related. The easiest one to understand is hydrostatic or water-based pressure, right? And that is just the gravity effect, right? There is gravity's pulling fluid and everything down towards the floor. The other pressure-based issue that's a little trickier is called oncotic pressure, and that has to do with the chemistry and the proteins that circulate in our blood. They actually keep fluid in the blood vessel where it belongs. But if the protein mix gets wonky, then we can actually start having water diffuse out of the blood vessels into the tissue. So that's a loss of oncotic pressure. The third issue is how leaky or permeable are the blood vessels. So capillary permeability is another issue that comes up a lot with respect to the swelling and buildup of fluid in the tissue. The fourth big issue that comes up is the systems that drain it, right? So how easily can fluid get out of the leg? And that's specifically the venous system, which we'll talk about in some detail, I imagine, and the lymphatic system, which brings fluid out of the tissue specifically and circulates it through the lymphatic channels up into the veins eventually.
Okay, so let's go through each separately. The 12 main causes of swelling aside from an acute injury. And since you talked about the leaky vessels, let's talk about chronic venous insufficiency first, causing the leg swelling, and what symptoms make venous disease one of the most common sources of daily swelling.
Yeah. Venous disease, chronic venous insufficiency, particularly, is terribly common. And the way I explain it to patients, it's a gravity problem. So the veins bring blood from the floor or from the feet, really, back up to our heart. And they, unlike the arteries, got the evolutionary short stick. Veins cannot pump themselves, they don't have any muscle in the wall like an artery does. That means our muscles are required to bring blood from the floor back up to the heart. And I think of it like squeezing toothpaste out of a tube, right? Every time your muscle squeezes when you walk and you squeeze that muscle, you squeeze the fluid and blood moves upward towards the heart. But you can imagine the minute that you relax or you sit down to enjoy a cup of coffee on a park bench, the muscles are now relaxed and blood wants to start falling back down to the floor with gravity. What is supposed to happen is that there are these one-way flapper valves on the inside of the veins that are supposed to flap shut as gravity starts to pull blood, and then just they're going to hold it there. But in venous insufficiency, those valves are damaged and the valves end up becoming leaky. And then gravity is allowed to pull that blood all the way back down to the floor. What causes leaky valves? What causes blood to accumulate down back to the floor with gravity? It's all kinds of things. There's usually a family history component. If I see varicose vein patients, I'll say, do you have other people in your family with legs that look like yours? I'll say, oh yeah, mom and grandma and my aunts all had all these, spider, snake-like veins on their legs. Absolutely. Pregnancy and hormone changes in women can do it. Increased pressure in the abdomen can do it. So if you have fluid buildup in the abdomen, like ascites, or a lot of visceral adipose tissue, excess weight in the abdomen, excess fat in the abdomen. That is how obesity can contribute to venous insufficiency, because there's more pressure weighing down and the veins have to work harder. The blood has to work harder to get back up to the heart. And then blood clots can do it. The blood clot causes a stretch of the vessel. And once it stretches out, the valves no longer coapt or touch. And so then they become leaky. For all those ways, we get leaky valves over time, and blood falls back to the floor. As that blood gets down there, it accumulates, and eventually it works its way out of the vessel into the tissues and causes all that swelling.
So I want to take a little bit of a deeper dive into deep vein thrombosis, DVT, and the signs and symptoms of that, because I think that that's critical, and that could not only be leg threatening, but life threatening very quickly.
Sure. So chronic venous insufficiency, we just talked about, that's leaky valves. That is heaviness, aching, swelling, itching, and it tends to be a very gradual progression. It could be one leg or both, but people, if you ask them, well, how long have you had this feeling of heaviness, or, your legs really barking at you at the end of the day? It tends to get worse. Legs feel good in the morning after we've been flat all night and the fluid has drained out of the leg. Then the minute we put our feet down and gravity starts working against us, we start building that fluid up. So people will say it's worse at the end of the day. And they'll say, well, I don't know, months, maybe years. It's just been slowly getting worse.
Mhm.
On the other side, when we have acute deep vein thrombosis, that tends to be a very sudden onset of pretty noticeable swelling. It can be tender, especially in the calf or the thigh muscle. One leg, it's usually not both. Typically, it's just one leg, and it's really out of the blue, and it's really a very sudden marked change. That enough would be by itself enough to go in and get checked out. But the really concerning alarm symptoms would be chest pain, any shortness of breath, any coughing up of blood. All of those things would suggest that perhaps that clot has now traveled to the lungs and become a pulmonary embolism. And that is absolutely a life-threatening emergency. And that's call 911 right away.
And, with chronic venous insufficiency and deep vein thrombosis, they can both rear their ugly heads because of an airline flight. I know that I ended up
Sure,
discovering
I
when I
would
had a
say,
little bit of CVI.
DVT, yeah, the you know any period of immobility can trigger a DVT. So whether that is you are laid up in bed because you had an injury, or whether that's a long car ride or plane ride, any period where we are immobile, the leg muscles aren't squeezing, they're not moving that blood back up to the heart where it belongs in a timely fashion. That causes what we call stasis, or blood just sort of sticking around in one spot and pooling. And when that happens, blood tends to clot. Um, Chronic venous insufficiency is usually caused by years of prolonged standing, or prolonged, sitting, and your symptoms can get worse if you are sitting for a prolonged period of time and not squeezing your muscles, but it's typically not brought on by that. And I think this is this brings me to a very important point, which is varicose veins and chronic venous insufficiency is not a significant risk factor for the development of DVT. So, having varicose veins, having heavy, achy, swollen, itchy legs is not a danger. It is not a threat to your life. It is not a threat to your leg. The only reason to get it treated is if you are still very symptomatic despite conservative treatment. But you should not get it treated because somebody tells you you could get a blood clot, because that's not more likely. In fact, the treatment of chronic venous insufficiency, the biggest complication, not the most common, but the most serious complication of that treatment would be developing a deep vein clot that could potentially go to the lungs. It's very uncommon, but if it happens, that's pretty devastating.
And with chronic venous insufficiency, I have to put out a little bit of a warning not to jump. I know there are a lot of facilities, a lot of vein clinics now, and they do jump right to a minimally invasive treatment, such as ablation or a venous seal, or I think it's called venous seal. I think that's the one my dad had, but they did 4 procedures on my dad to close up the veins, and it did not make a difference in his symptoms. What actually made the biggest difference was a simple over the counter pill that he got off Amazon that Dr. Miguel Montero Baker, a vascular surgeon, suggested to him. After all of that didn't work, I flew him to Houston and said, because I didn't know you at that point, or else I would have brought him down to you, Dr. Johnston. But he said, all you need is something called Venexa or Vasculera, and it made all the difference in the world for him.
Yeah, that's really interesting. We do not use a lot of the micronized polyphenol flavonoid fraction, or the MPFF, the diosmin and hesperidin, which are the quote unquote venotonics or the supplements that have been used, but they actually are in our guidelines and they can help with some symptoms of venous insufficiency. I am surprised that that helped when the ablations didn't, but again, when I counsel patients with venous insufficiency, many of them come because they're scared that they might get a blood clot. And once I say, look, you're not any more likely to get a deep vein blood clot from this than somebody who doesn't have it, you do not have to get this treated. Half of them walk away and like, oh, thank goodness, now I can just go about my life. The other half are still symptomatic and either don't enjoy wearing compression, or when I lived in Sacramento, it was so hot for 6 months and they worked outside and they couldn't be in compression all the time because it's hot and it's gross. For all those reasons, you should consider a treatment if that helps. But we also use compression therapy. I've never heard of somebody getting really hurt with a pair of socks. I have heard of somebody getting a blood clot from an ablation procedure. So the socks are one thing, and then the MPFF, or the venotonics, the micronized polyphenol flavonoid fraction, are the supplements that can be used to help. And again, as long as they're high quality and you know where they come from and they've been tested, then by all means try that conservative approach before going to more invasive procedures.
I almost feel like we should have done a whole segment just on this, because I'm going down a rabbit hole here. Just thinking, we had a patient that she was prescribed by her doctor some sort of electronic compression device. He told her to go on Amazon, and it's contraindicated if you have CHF that you don't use these types of devices, but yet they're readily available. And we have patients that are sharing those devices in our groups and saying, hey, what do you think of this? My doctor says I have CVI. I'm going to go ahead and just buy this. And I think that's really dangerous.
Mm. I haven't seen those for venous insufficiency. I've certainly seen the pumps for lymphatic disease, um, but yeah, I'm not aware of the particulars about that and CHF. I can imagine that it is potentially contraindicated, but I'm not familiar with that in a deep way.
Yeah. And so maybe they are for that. But when you look at what's on Amazon and they say, oh, if you have leg swelling, well, you should use this. They don't really, and patients just don't know the difference. So just a warning to patients, make sure you do check with your doctor and make sure that you have the right
Absolutely.
treatment for the right diagnosis before you spend any money. What about peripheral artery disease? How does it contribute to swelling, especially in more advanced stages of ischemia?
It's not a huge reason, but I will say that if you are somebody that has a wound that is potentially infected or significantly inflamed, that can certainly result in swelling. And the other time I really see it is in reperfusion. So after you have been treated for your PAD with a bypass or a stent, then there's a lot of blood flow suddenly getting to this limb that hasn't had flow in a while, and all of the flow dynamics are a little bit off, and we often will see people have a fair amount of swelling after we've intervened on their leg for PAD, and that can also actually be associated with some increase in pain, which is always scary, right? Because we usually hope that pain gets better, and eventually it does, but initially called a reperfusion injury and comes with some discomfort or pain and some swelling. Finally, occasionally you'll see people that have such bad PAD with rest pain that they want the foot dangling at all times because gravity is taking that last little red blood cell down there with oxygen. And that's the only thing that helps alleviate their pain. And because the leg is down all the time, we can
Yeah.
see some edema from that. But the impairment in arterial circulation by itself tends not to generate a huge amount of swelling, but it does cause lots of vascular resistance. And so there's, the vessels are dilated trying to get, again, every little last red blood cell down there with any oxygen. And so you can see a little bit of swelling in the end stage.
Can we talk about lymphedema and what makes its swelling pattern different from venous swelling?
Yeah. Lymphatics, lymph nodes are kind of the way stations, and the lymphatic channels are the small, tiny vessels that bring all the fluid. Again, that's water, proteins, everything that comes leaks out of the vessels and should come back through the lymphatics, through the lymph nodes, back up into eventually the circulatory system. Lymphatics are, most people think of lymphedema classically as somebody with breast cancer who has an operation under the arm to remove the lymph nodes that might have cancer in them. And then the arm is perpetually swollen. Like that is the clinical classic lymphedema story that doctors and many patients are familiar with. But it can absolutely happen anywhere in the body. Lower extremities can also be subject to lymphedema, and lymphatics can be disrupted from infection. So, in the developing world, filariasis is actually the most common reason for people to have severe lymphedema and causes something called elephantiasis. It's a very disabling, very morbid condition. In the developed world, sometimes it's trauma. So a fractured bone or a disrupted joint can damage those very fragile. The lymphatics are very small; they're 1 to 2 millimeters, and so any disruption in the tissues, prior surgery, trauma, infection, anything that creates swelling in the lymph nodes, cancer, radiation, chemotherapy, any of that could disrupt lymphatic flow. And then again, we get the swelling. It tends to be more protein rich fluid. And over time, there's a lot of swelling and inflammation that occurs in the leg. And bad lymphedema is a really difficult problem to treat. And, lymphatic drainage and massage is helpful. Leg elevation can be a little helpful. And, again, some of the pneumatic or electric compression devices can be used. But the skin gets very woody and inflamed and thickened, and it can be really, really challenging if it gets out of control.
Okay, the difference between lymphedema and is it lipedema?
Yeah,
Lipedema.
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 Lipedema is a lipodystrophy, meaning a fat distribution problem. And there is an excess of very inflammatory adipocytes or fat cells that accumulate in the leg. So clinically, the distinction tends to be that lipedema is limited to the leg itself. There's a cuff sign. So the ankle and below the foot, the toes are unaffected. In lymphedema, the foot is involved, and there's actually something called stemmer sign where the uh, second toe gets this very square appearance, and you can't even pinch the skin of the toe anymore because it's all involved with this lymphatic
Mm.
tissue and swelling and inflammation. Lipedema spares the foot and the toes. So you will not have a stemmer sign. And it's very tender. Patients with lipedema tend to have very like it hurts and they have easy bruising. There's something about the tissues that is just not normal. And they'll say, I can lose weight everywhere. I can get skinny arms, I can get a skinny belly, and I
Ah,
cannot lose weight in my legs. And the fat is just a different type of fat cell. It's pathologic in some way. Um, Siobhan Huggins is the woman I know who's done the most sort of community advocacy and patient advocacy with lipedema. And she personally has had some very good effect of therapeutic ketosis with that. So I would encourage people to seek out Siobhan Huggins and the lipedema patient advocacy group that she runs, and for more information about that very challenging condition.
that's really helpful. So, what symptoms or patterns suggest swelling might be coming from a systemic issue, such as heart failure, kidney disease, liver dysfunction, or thyroid problems, even?
Some of this is just clinical suspicion. Like, do you have a history of heart problems or kidney problems? So some of it's a little common sense, but bilateral leg swelling, that's quite sudden in onset, right? Again, we mentioned that venous disease, chronic venous insufficiency, tends to be slowly progressive, months to years. Varicose veins, spider veins, any visible vessels can be pretty easily attributable to chronic venous insufficiency. But if you are short of breath, then maybe it's a heart problem. If you have kind of foamy urine, like soapy looking urine, that could be protein spilling into the urine from kidney disease. And if that's accompanying your leg swelling, then that's probably a clue. Um, Thyroid disease is a little less common, but you can have either edema or myxedema from thyroid issues. But again, lab tests would be the sort of first place to start with this, because they can check your urine for any protein. We can check your BNP to see if there's any strain on the heart. We can check your thyroid levels and check to see if there's any significant abnormality. So pretty simple, straightforward, normal blood tests would be able to help us understand. The last one would be liver disease. Again, we talked about the protein content in blood, helping keep fluid there instead of out beyond the blood supply. Liver disease can change the proteins if the liver is very sick, and people may also get fluid buildup in the abdomen called ascites. So again, that should be something we can determine pretty straightforwardly through history and laboratory testing and physical examination.
Yeah, we just had a patient that in the reason, I even, I ask about it is because she just felt so brushed off by her doctors. It was one of those situations where she went to the emergency room. She's been there twice, and all they did was they couldn't give her a definitive reason for why she was blowing up acutely like a balloon. Her whole body, I mean, her weight significantly changed, and they sent her home with Lasix, and she was in severe pain. She could barely breathe. She was just in so much distress, could barely talk, and they sent her home, and it really frustrated me because, of course, that's not where we typically have our space, our lane for advocacy, and, I think this information is going to be very helpful for her and for so many others that will have to advocate for themselves to say, "Hey, doctor, we got to do a little bit further testing here. You can't just send me home with some Lasix and, I'm sitting here at home getting worse, wondering if I'm going to die." And that's what she thought.
Yeah,
It was really sad.
very challenging, very challenging. I feel my heart goes out to that patient. And the other thing that we haven't talked about yet would be, was it potentially a side effect of a medication? Because there are a
That's
lot of
what,
medications that
yeah.
can suddenly cause swelling, and that also is something that comes to mind right away, right? Was this a bad reaction to a new blood pressure medicine? Some of the calcium channel blockers can cause significant swelling. Steroids like prednisone, some people get a prednisone pulse for COPD
Yeah.
exacerbation or an arthritis flare, whatever it may be. Steroids can absolutely do this. Hormones can do this for some people. So growth hormone, sex hormones like testosterone, and some of the and estradiol, like in larger doses, can cause some fluid retention. It's usually temporary, but it can be pretty alarming if you don't warn people ahead of time that it might be coming. Creatine, right, the very common supplement that people are now taking in droves, like great for muscle support, but if you take a lot of it, you will get fluid retention, you will get swelling. Absolutely. And so just being aware that there are side effects to new medications or changes in dosages, that can also be part of this.
Should we talk about salt?
Sure. About 25% of the population is very salt sensitive, meaning that a lot of increase in dietary sodium can result in both elevated blood pressure and water retention if you're not taking in enough water to get rid of all the salt that you've just taken in. Typically, if that's you, the sources of salt are going to be highly processed foods, things in a box or a bag or a can, like Campbell's soup or other types of prepared meals that typically does not come from the salt shaker that you have on your table. But if you are salt sensitive, particularly if you are on medications for blood pressure, some of the salt
Mm.
substitutes that use potassium instead of sodium can be very helpful, not only to reduce sodium, but actually potassium can be very helpful in helping modulate blood pressure. And some people actually find a reduction in blood pressure when they start supplementing with some potassium. Do that carefully under a physician's guidance, of course, right? I don't need to tell you that, but
My dad and I are getting ready to go on a cruise, and we have a list. I mean, already we have to be gluten free, dairy free. This time around, because we did it once before, and we just found out that salt is a big issue. They use a lot of salt in all the foods there. And I had a dress I wore on Christmas Eve, and by New Year's Eve, it didn't fit me. And then when I got home 2 weeks later, it seemed to fit me again. And I was thinking, what the heck? How is this possible? And it was because there was so much salt in the food. So this year we're adding no salt to our list, and I'm bringing my own shaker of Celtic salt. So if I do need it or he needs it, we can use that and use it sparingly.
yeah, and drink extra water. I think the other thing is if you're on a cruise ship, you may not actually have your water bottle with you, or your glass by your bedside all the time, and it can be the dehydration can actually really compound that extra sodium load and cause people to retain.
So overall, I know you mentioned, tests along the way in our discussion, but let's just sum it up for everyone. And I know there's no one size fits all, but the patients are looking for maybe a little bit of a checklist. Like, what tests should patients be asking for to ensure that they do get a complete evaluation for leg swelling rather than just being prescribed a diuretic like Lasix or a procedure like an ablation? And I know those would be for two very different things, but to put you on the spot and give us the laundry list.
So I think, just have a conversation with your physician and ask, why do you think my legs are swelling? How do you know it's not my heart, not my kidneys, not my liver, right? Those are not going to be terribly common, but the doctor who sees you and evaluates you should be able to tell you or provide some kind of plan to evaluate those situations and make sure that's not the case. If it's not that, then is it a side effect of my medication? Am I on any supplements that might do this? Have that conversation. Now, if you think it's just my veins, then how did we know that? Before you can get an ablation, you'll have to have what we call a reflux venous ultrasound. So that is not only looking for the blood clots in the deep system, which is what you'll get in the ER if you go for swelling, but to get the diagnosis of chronic venous insufficiency, what we will have is a reflux study that actually measures how leaky those valves are that we talked about and how
Mhm.
much blood is flowing the wrong direction back down towards the floor. Before you can get an ablation, especially covered by insurance, they'll have to measure that. Now, if you're going to a vein center that's cash only, they may not care and they may ablate you no matter what. But before I would have that done, I would say, prove to me that actually I have leaky valves and that this is really going to be meaningful. And should I try compression therapy first? Should I try some leg elevation first? Let me know if that's going to help, right? So, ablations are fine if you're still symptomatic with compression or you are bothered by the cosmetic appearance of your varicose veins. Like those are reasonable indications to do a procedure. But if you are not that symptomatic and you're happy just wearing compression, then by all means do that. Diuretics are okay if you have high blood pressure and we think that there's a reason like heart failure that you're accumulating too much fluid. But Like, get somebody to actually walk you through the logic behind all that. And that is your right as a patient, is to have somebody explain why they think this will help.
When it comes to the venous reflex test, the ultrasound, we had recently on, and we actually have a pad test podcast that we do on a weekly basis where we look at ultrasound results and such. And one of the tips that she gave, she's had patients that would come in and they would walk flat-footed. So they were not actually getting their second heart, their calf muscle, to really pump. And all it took was giving them some PT and getting them to walk properly that actually solved their entire issue. But when you're getting that venous reflex test, she said it's really important to get the technologist to move the foot at a certain point in that test. And I thought
Mm,
that was interesting, a point. And it's hard, I know, for patients to know whether or not they need it or whether or not a technologist should or shouldn't do it. But it is worth making sure that they're actually, whatever lab you go to is fully certified for vascular, and that they specialize in legs, to make sure that you are getting, the ultimate gold standard in testing for venous. Also, she
yeah,
tests all of her
yeah.
patients not only laying down but standing up.
Oh yeah, for sure. I mean, and that should be part of that's part of the reason they don't really do them in the hospital, is because typically they're done on a tilt table or some way that we can have patients have gravity demonstrate for us whether the valves are incompetent. So I do think that is important. But again, as I tell my patients, varicose veins, chronic venous insufficiency, heaviness, swelling, itching, aching, as long as you do not have an ulcer, it is not a threat to your life. It is not a threat to your leg. And what we choose to do about it is entirely dependent on your symptoms and how aggressive you want to be in management. If you want to be like me and just go forward with compression socks for the rest of your life, great. There will be days where you don't want to wear them. It's okay, right? You don't have to wear them to the pool. You don't have to wear them on a cruise. Your legs will be a little more swollen and achy on the days you don't wear your socks, and it's going to be okay. If you are really bothered by the symptoms or by the cosmetic appearance of it, then we can pursue treatment, right? Most people do well and it's generally low risk, but it's not zero risk. And I have seen a couple of really bad outcomes, but that's over hundreds or thousands of patients that have been treated. So, it's generally, and by the way, they will come back if you are not careful. So I also tell patients who get ablations, if you're not wearing some compression some of the time, please expect to come back to my office in 10 to 20 years with recurrent symptoms, because the same physiology that led you to have leaky valves in the main superficial veins in the first place will potentially cause more leaky valves in other veins that are accommodating down the road. So if you do not want them to come back, then do your best to wear some compression some of the time when you can stand it.
Thank you so much, Dr. Johnston. You are always a wealth of information. I think that this was a brilliant, brilliant segment. So much helpful information for so many patients out there. If you want to follow Dr. Johnston, make sure you go to youtube.com/, the @ sign Lily Johnston MD. Do like her videos, subscribe to her channel. She is amazing. So much more information than even what's being provided here, because she also specializes in metabolic medicine. And so, talk about longevity and information to help you live a longer, healthier life. That's where you're going to want to go, above and PA above and beyond PAD information. But you want more information about peripheral artery disease, make sure you do like this video, subscribe to our channel at youtube.com/, the @ sign the way to my heart. And don't forget, we're always here at the Leg Saver hotline at 1-833-PAD legs.